continues to be an important and major public health problem in the region of the Americas. And it's very important for everyone to be aware that there is an urgent need to implement effective suicide prevention strategies in the countries in our region. And we really invite health authorities to really prioritize public health strategies aimed at suicide prevention. And I'm going to be sharing with you why we believe this is so important. Next slide, please. Next slide, please. Okay, so let's start by sharing with you some recent data that we have. In fact, this is one of the first times that we are sharing this data, which is going to be part of our new regional suicide report with data up to 2019 that we received from member states. So we know that there is an average of 93,000 deaths by suicide per year. And this is the average between 2015 and 2019. So we have a regional rate that is 9 per 100,000 population in the Americas region. And when we look at the data that we have since the year 2000, we see that there has been an increase of 17% on the suicide rate in the region of the Americas. Next one, please. We know that the majority of death, in terms of number of death, are in the subregion of North America, and the subregion that has the lowest number of deaths is the non-Latin Caribbean. But we also know that on the other side, the non-Latin Caribbean has countries with very high suicide rates. Next one, please. When we put together the data and analyze suicide rates per countries, we see that the vast majority of the countries have a suicide mortality rate that is below 10 per 100,000. But there are some countries in the region who, as I had just mentioned to you, have very high rates, and they are among the countries who have the highest suicide rates in the planet. So we have Guyana, Suriname, we have Uruguay, the United States, Haiti, Canada, and Cuba. So these are the highest suicide rates in our region. Next one, please. We know that the majority of suicide the majority of death by suicide are among men in the region of the Americas, and this data is very similar in the different subregions of the Americas. The proportion of male suicide deaths was 77% in the region, and a little bit lower when we look at some specific subregions. And this is data that is very important when we think on how to develop a suicide prevention strategies, because this helps us to see which specific groups we might be able to target at the country level, but also which type of means to suicide specific groups might have access. As we will discuss a little bit later, and I'm sure the colleagues will elaborate more in their presentations, that preventing access to the means of suicide is one of the most effective suicide prevention interventions. Next one, please. In terms of age, we know that the highest suicide mortality rate was among individuals older than 85 years old, so 20 per 100,000. But the majority of suicides, so the greatest proportion of people who die by suicide, is among middle-aged groups, 40 to 69 years old. So this is a compilation of data for the whole of the Americas. Next one, please. And well, how could we have a discussion today on suicide prevention and on mental health without mentioning the impact of the pandemic that we are all going through? So we know that the pandemic influences many risk factors known risk factors for suicide. We know that many people are going through financial and job losses. There is an important amount of research now, including from our region, showing an increase on the incidence of mental disorders, increase on harmful use of alcohol, and all the barriers towards access to healthcare that people are facing today because of many disruptions on health services that were caused by the pandemic. There is also an increase on some indicators related to violence, especially related to domestic violence. We know that this can also be an important risk factor for suicide, and all the sense of isolation, lack of social support, all the changes in the society that the pandemic brought to us. It's still early to conclude if there has been an increase or a decrease in suicides. Because of the pandemic, we have not enough data to be able to do proper analysis up to now. We know that some countries are reporting an increase, others are reporting decrease. So it seems to be a variation depending on country and on specific social circumstances. But no doubt, many risk factors for suicide have increased during the pandemic. So this should be an alert to us and again highlight the importance of working on suicide prevention. Next one, please. And when we put together also data based on a questionnaire that was sent to focal points in other countries in the region. So in fact, this was a questionnaire elaborated by the World Health Organization and that we were sending to country focal points to understand what was the level of disruption of health services, including mental health services during the pandemic. And what we could see is that suicide prevention services have also been disrupted during the pandemic. So from the countries who answered the survey, in fact, 56% of the countries described a disruption on their suicide prevention programs because of the pandemic. So this is another area of concern. Next one, please. Well, having said all that and having highlighted here the key suicide indicators in our region, I think it's also very important that we highlight that the WHO has launched this year a new guideline on suicide prevention. So it's a evidence-based suicide prevention approach that follows 7 core pillars, being situation analysis, the importance of multi-sectoral collaboration, the importance of awareness and raising and advocacy, capacity building for suicide prevention, the importance of investing on suicide prevention from a financial perspective, something that we have been advocating for so long for mental health services. It's the same here in terms of suicide prevention, and the importance of surveillance, monitoring and evaluating programs, because only by understanding the patterns at the country level, which groups are more at risk, we will be able to shape the strategies to aim to decrease the suicide at the country level. And it's also important that I emphasize that this guidance called Live Life, the version in Spanish is also available now, and you all can have access in the PAHO webpage. Next one, please. Well, the guideline also reinforces the importance of 4 key effective interventions for suicide prevention that are interventions that need to be implemented from a public health perspective. So the first one is the importance of limiting access to the means of suicide. The second one is the importance of interacting with the media for responsible reporting of suicide. The third one is the importance of working in schools, working with adolescents on reinforcing and strengthening their social emotional skills so they can cope and they can face this important phase of their life with skills to overcome problems and challenges that the life bring. And the fourth intervention is the importance of early identification, assessment, management, and follow-up of anyone who is affected by suicidal behaviors. So it's, of course, many times it's difficult to implement the four strategies at the same time, but in our dialogue with the countries, we really encourage that the activities that are implemented at the country level, they have as an objective to have the four components implemented, but of course, each of them might be started at different time points. Next one, please. We, here at the Pan American Health Organization, we also have been providing our contribution to suicide prevention. So there is a very intensive work that happens in our country offices with the Ministry of Health, but also with other components of government. And one of our contributions is to compile data so we can be regularly aware about what is happening in our region. So we have produced the 4 reports already on the suicide mortality in the Americas. And as I mentioned to you, the data that I have shared here with you is part of the 4th version of such a report that is going to be made public, hopefully in the coming weeks or in the coming month. Next one, please. Suicide prevention is also part of the regional plan of action on mental health for the Americas that we have developed together with member states. So we are regularly monitoring the regional suicide rate in the Americas. And in fact, when we review the indicators of our regional mental health plan of action that we are reporting in a couple of weeks to the governing bodies of the Pan American Health Organization, this is one of the indicators that the region is not on track. So this is an area that we really need to put emphasis now and in the years to come. And I have shown you the data on how the regional suicide rate has been increasing over the last years. Next one, please. We also have material that has been produced, some material produced by us at PAHO, material also produced by the World Health Organization, and we have been using a lot that material with member states in many capacity building activities that we have developed. You might be aware about the key ones. One is the MHGAP intervention guide that has a specific module on suicide, which is also an important element on the management of people with suicidal thoughts. So the MHGAP is an important tool for us to develop the capacity in the health system on managing and supporting people with the suicidal ideation. But we also have a virtual course on preventing self-harm and suicide that I really invite you to give a look and engage in those courses. Next one, please. We have also developed some courses on engaging with the media on suicide prevention. We know that many times media had produced material and statements that unfortunately could mobilize or increase probability that people who are really facing a difficult situation could advance in terms of suicide. So the material is really on helping media on how they report those incidents and how they can do it in a way that in fact help people who are facing those difficulties to really understand that they are not suffering alone and that there are possibilities to get help and support around it. Because that's in fact exactly what we want. We want people that this is also in fact acting on the stigma that the suicide has around it. So the idea is really mobilize journalists to when they speak about suicide, to do it in a way that mobilize people to understand what they are going through and to look for help. Next one, please. We also at the last stage of putting together in the PAHO webpage data on the burden of suicide in our region, so anyone can have access, can select the different indicators that are available, and have instant access to the data that is available in our region. So this is also important in terms of helping countries to understand where they are and see the urgency of action. Next one, please. Well, I think it's again very important to emphasize how suicide prevention continues to be a public health priority in the Americas. And we all know that, but we know what has to be done. We know that effective interventions exist and they need to be implemented. And in order to be able to do that, it's not only the job of health, it's a multi-sectoral collaboration. Various departments and levels need to be included. Knowledge, voices, and experiences really need to be shared if we want to advance with suicide prevention. Next one, please. The countries have a key role to play. Countries can be in the best position to really find ways within their administrative and legal mechanisms to limit access that people can have to means of suicide, being through policy regulation or also coordination among the different sectors. We know how effective it can be limiting access that people can have to pesticides. This is a very evidence-based intervention that can really reduce suicide in countries. For countries where pesticide is the main means of suicide, limiting access to fire guns is another important strategy that can also reduce access, suicide rates at the country level. So it's also important that countries play that role on limiting access and also reviewing existing legal frameworks regarding the availability of services and mechanisms of support that people can have at the country level and can also prevent suicide. And last but not least, the importance of strengthening national systems of surveillance and information, because it's with data that we are able to refine and adapt the strategies to have the most effective outcomes. Next one, please. Here, I'm just sharing with you a few resources that we have available. So the PAHO webpage has a section on mental health, has a section on suicide prevention. So most of the things that we have been discussing, they are available there, and all of you can have access. Next one, please. And thank you very much for your attention. So this is the link to our webpage. Thank you very much again, and it's a pleasure to be here with you commemorating the Suicide Prevention Day. Thank you.
Thank you very much, Dr. Oliveira. It is excellent presentation, so much information about what's happening in our region. It's alarming how suicide rates have increased in this region over the past decades and continue to remain high. And the theme is so relevant, creating hope through action. And so the fact that you mentioned so many important resources, so that colleagues that have joined us, we have over 480 that have joined us this afternoon. There is access to these resources that were mentioned. There is the link that we will be sending you a link to this presentation, and you'll be able to go over that and listen to them, and you also can visit our web page. So please feel free to continue with us and to type your questions in the chat if you have any questions for our presenters at any time. We'll have time. I'm sure we'll have time to be able to address them as best as we can. So this time it gives me a pleasure to welcome a dear friend and colleague, Dr. Hazel Otello, who is the Director of the Mental Health Unit of the Ministry of Health in Trinidad. Dr. Otello is currently the leading the implementation of Trinidad and Tobago mental health policy, and which aims to fully decentralize the mental health services. She also chairs the local mental health and psychosocial support technical working group, the TWG, which Trinidad has been very, very active from last year, which is responsible for coordinating the local mental health response to COVID-19. The mic is with you, Dr. Otello. Thanks for joining us and thanks for accepting our invitation. I think you're muted, so we're not hearing you.
Good afternoon, everyone. And it's indeed my privilege this afternoon to share with you about suicide prevention in Trinidad and Tobago. And I'll go straight into my presentation. So I'll start with giving you a bit of our suicide statistics as reported in the World Health Organization 2019 suicide rates document. And as you would see on this slide, our national average is 8.3 per 100,000 population as of 2019. And you would see that that is a bit lower than the global average of 9, as well as the regional average of 9. It is also interesting to note that that figure compares with how that figure compares with the national average in the 2018 publication, when it was 12.9 per 100,000. So our national average has in fact gone down by a small but significant percentage. Looking at suicide deaths in Trinidad and Tobago for the year 2020, you would see that but when we look at the gender distribution, it's been significantly male in accordance with the usual trends. There's actually a 3 to 4 times greater predisposition of men to die by suicide compared to women. And this has been a consistent trend in Trinidad and Tobago, where we've observed that men tend to use more lethal methods of suicide, with women having more attempts and more episodes of self-harming behavior without actual completed suicide. Looking at ethnic groups, our East Indian population is the one that is most represented in terms of percentages, followed by the African population. And we have quite a large mixed population, and that comes in next, with a very small amount being attributed to Caucasian persons and persons whose ethnicities were not reported. Looking at methods of ending one's life, hanging is currently, according to the most recent statistics, the most utilized method, followed by ingestion of poisonous substances. In previous years, pesticide poisoning was reported as the most common method. So this is actually a change in the trend. And that previous greater predisposition for it to be ingestion of poisonous substances was largely associated with our agricultural industry and the easy access to toxic pesticides and herbicides, weedicides, and those things within practitioners of that industry. I will now go to the slide that shows you a little bit about the distribution by age. And you would observe that the over 60 population is showing an increased predisposition towards suicide. And that was not always so. In fact, in previous years, we observed higher numbers among the 15 to 19, 15 to 29 age groups, as well as the working age group, the 30s, 40s, and 50s. So that is something we have to keep our eyes on and address as is required. We want to talk a little bit about suicidal behavior in Trinidad and Tobago, and by that we refer to the entire umbrella term for the range of behaviors relating to the act of suicide. So we're talking about suicidal thoughts or ideation, attempted suicide, and non-suicidal self-harm with varying levels of suicidal intent. And what is important to note in our country is that we have to pay more attention to these issues. We have to do more research and put in place more interventions, because self-harm and attempted suicide are becoming more common, particularly among our children and adolescents, even within the primary school age group. That's the under 12 age group. So it's something that we need to pay a lot more attention to. I will now direct your attention to, let me change that slide. Why is it jumping back? Yes, the World Health Organization Global School-Based Student Health Survey. And I've put up the Trinidad and Tobago results from that survey, where you would notice the percentage of students who've attempted suicide or who've thought about suicide. You see again an increase among the girls compared to the boys. So within the younger persons, that is something that we need to pay attention to. This survey was last done in 2017, and a total of 3,869 students participated. And in addition to the data provided there, the Ministry of Education also reported receiving 565 referrals between 2012 and 2017 for self-harming behavior through the Student Support Services Division, and that applied to both primary school and secondary school aged children. So what has been happening with regard to suicide in Trinidad, suicide prevention, in Trinidad and Tobago? Over the years, a number of things have been happening, and I will take you through some of them in this slide. We have a non-governmental organization, the NGO Lifeline, which was established in 1978. And Lifeline's mission is to befriend the despairing and suicidal, decreasing violence against self and others by providing a client-centered 24-hour listening service and outreach to those at high risk, strengthening families and communities. We are proud to note that the chairperson of Lifeline is currently one of the co-chairs of our MHPSS, or Mental Health and Psychosocial Support Technical Working Group. And this group was established in 2020 to provide coordination among MHPSS actors during the pandemic. MHGAP training has been provided to health workers in psychiatric services, in accident and emergency departments, and in our primary healthcare services, empowering them to provide the care and treatment that is needed for persons experiencing suicidal thoughts or demonstrating suicidal behaviors, ensuring that appropriate levels of intervention are available. A number of persons with lived experience are also involved in varying levels of advocacy. And we have other NGOs such as Mindwise, Not Okay, Mindful Kites, and Lifeline, all engaged in mental health promotion specific to suicide prevention. In addition, there are support groups that are run privately by survivors of suicide. This slide that I've now taken you to takes us to most of what has been happening since we began to try to develop a more comprehensive, collaborative national response to suicide prevention. So in 2017, as you would note on this chart, the Ministry of Health, in collaboration with the Pan American Health Organization, PAHO, who are hosting us today, facilitated a suicide prevention mission which included a week of stakeholder engagements to assess the status of suicide prevention in Trinidad and Tobago. Stakeholders in surveillance and epidemiology, media, research, mental health, social services, law enforcement, as well as service users and advocates, to name a few, were invited to map the current interventions and identify the challenges, gaps, and opportunities for more comprehensive approach to suicide prevention. In 2018, a multi-sectoral working group was convened to determine the key priorities for a comprehensive national suicide prevention strategy. And in 2019, the Ministry of Health, in collaboration with PAHO, facilitated a wide technical stakeholder consultation on a draft suicide prevention strategy. A final document was submitted to the Ministry of Health's executive and PAHO for review and comments in 2020, with each strategic area identifying clear goals and objectives to be accomplished by 2030. The development and implementation of national media guidelines for responsible reporting on suicide was another significant milestone in the national response to suicide prevention. Reporting by the media, as you were just told a short while ago, is an important component of managing suicide and associated suicide-related behavior in a country, since attitudes and knowledge about suicide are influenced by what the population is exposed to in the media. So media guidelines were developed. A media sensitization seminar was initially facilitated in 2017 to explore the role of the media in suicide prevention and to draft these guidelines. The draft document underwent a series of reviews by key stakeholders, including an international panel of experts, to ensure consistency with best practice and to assess the likelihood for compliance by the media. They were then shared with the relevant stakeholders for further feedback. And when that was obtained, those guidelines were finally approved and circulated. So those guidelines are being used today. They contain 11 best practice guidelines for reporting on suicide, and these guidelines were the first of its kind in the region. A monitoring and evaluation tool was subsequently developed. This tool rates all suicide-related news reports accessible online on the number of guidelines violated and the number of helpful information items reported. Media practitioners are then contacted based on their score and are reminded of the guidelines and provided with any additional resources that are necessary. Mental health promotion and stigma reduction through awareness-raising campaigns is another evidence-based suicide reduction intervention. As such, in 2018, the Ministry of Health collaborated with PAHO and an NGO called Create Better Minds, and together implemented a national mental health campaign on World Mental Health Day called Paint the Town Green, which was in fact the brainchild of Create Better Minds. That activity creates a space for public discourse on mental health and brings together a range of stakeholders across sectors to participate in the conversation and engender a more holistic and destigmatized understanding of the many issues surrounding mental health, including the issue of suicide prevention. This campaign was repeated on World Mental Health Day in 2019. Unfortunately, due to the pandemic, we were unable to do it in 2020, and 2021 seems to be heading in the same direction. Also in 2019, the Ministry of Health declared National Behavioral Health Week, and that's the week of World Mental Health Day, as an opportunity for further collaborative efforts in mental health promotion and advocacy at all levels of society. This was also an opportunity to highlight in the public domain the urgent need for more awareness of mental health in every setting, and suicide prevention is included in the promotional material on these occasions. In 2020, the COVID-19 pandemic introduced additional risk factors for persons who were already vulnerable to suicide, and it may have increased this vulnerability in many others as the entire world changed before our eyes. As such, the Ministry of Health, in collaboration with PAHO, facilitated the establishment of the MHPSS Technical Working Group, as was mentioned before. And as a result of this, a website has now been launched. It was launched on January 12, 2021, and it provides digital access to a directory of MHPSS service providers and serves as a one-stop shop for persons in need of these support services. It is noteworthy that a tab on this website has been created specifically to locate all the suicide prevention resources in one place for ease of access. And a few days ago, we added the World Suicide Prevention Day activities to that page. In 2021, despite many setbacks posed by the pandemic, the suicide prevention strategy, after having continued to be reviewed and revised and having feedback provided and such things, it has now been approved, and it is the National Suicide Prevention Strategy of Trinidad and Tobago. And we are currently working with PAHO on the development of a 2-year implementation plan for that strategy. In addition, we note that understanding the full scope of the problem of suicide requires efficient surveillance that will in turn inform the necessary interventions. As such, the Ministry of Health is currently working with PAHO and the National Suicide Research Foundation in Ireland to develop a national suicide and self-harm surveillance system for Trinidad and Tobago. So as you can see, in Trinidad and Tobago, we now have a strategic way forward with regard to suicide prevention. Our vision is a resilient, well-informed society that exhibits a proactive culture of wellness, where every human life is valued and it is rare for anyone to attempt suicide. Our mission is to build a collaborative, intersectoral response to suicide and self-harm with implementation of timely, effective, and accessible support systems, evidence-based approaches, and interventions for all. And our goal is a 1/3 reduction in the incidence of suicide deaths by 2030 in alignment with the Sustainable Development Goal targets. So, our strategic action areas are highlighted in this slide, and they include: 1, implementation of effective and sustainable governance and leadership for suicide prevention. Then we plan to focus on building a proactive, competent, and responsive health system to address suicide behavior and non-suicidal self-injury. The next action area is fostering a resilient society by promoting positive mental health and managing the risks of suicide. And 4, implement effective and timely surveillance, evaluation, and research to inform suicide prevention strategies. I thank you for your attention to my presentation. I remind you also that suicide prevention is everyone's business.
Thank you very much, Dr. Otello. We definitely appreciate and great to hear that, everybody, mental health, suicide is everybody's business. Interesting to hear about the changes in method, which makes it more important to be vigilant in what are these effective strategies, to implement so that this can be effectively addressed. I also want to congratulate you on the work that you're doing and to see that from PAHO, we have been accompanying you in this work of not the guidelines of responsible reporting on suicide, not only that you train the journalists, but that you also develop the M&E and you follow up by enforcing their adherence to this guideline. This is fantastic. It's that because it has the responsible reporting has been shown to be one of the effective strategies. So this is food for thought for our listeners. With this now, as I say, very interesting work, and thanks a lot. So we are delighted now to invite Ms. Paulina Del Rio to share with us her experience. And Ms. Paulina Del Rio is the president and co-founder of a foundation, Jose Ignacio, which is a nonprofit. And one of the interesting things about her work is that she's also has been doing a lot of group, facilitating group work, especially for teenagers and young adults, and teaching about suicide prevention and survivor care. Interesting work. The mic is yours, Ms. Paulina.
Let me unmute myself. Okay. I would like to perdón, voy a hablar en español. Quisiera cambiar el foco de las presentaciones que hemos visto hoy y mostrarles más bien la experiencia, la cara del suicidio, que no son solo cifras, sino detrás de eso hay personas. Y para eso quiero presentarles a José Ignacio. José Ignacio era un chiquillo habitualmente sonriente, que le iba muy bien en la vida, en el colegio siempre le fue muy bien, tenía amigos, era deportista, después en la universidad, él quedó aceptado en la universidad que él quería, no tuvo problemas, el primer año de universidad estuvo bien, tenía 19 años, cuando llegó el final del primer año de universidad, José Ignacio cayó en una profunda depresión. Recibió tratamiento psiquiátrico, psicológico, farmacológico, pero José Ignacio duró solo 5 meses enfermo y cuando hacía poco que había cumplido 20 años y estaba segundo año de universidad, José Ignacio se suicidó. Él era mi hijo mayor y por eso hoy estoy aquí contándoles desde la experiencia lo que significa el suicidio, la ideación suicida y el vivir el duelo después de un suicidio. Entonces les voy a hablar de mi experiencia personal muy brevemente. ¿Qué hice yo? Esto es una bomba atómica que cae en el patio de la casa, ¿no? Cuando un ser tan querido se suicida. Y yo estuve aproximadamente 2 años fuera del mundo, viviendo mi duelo de una forma que en realidad es algo tan doloroso e inesperado, que marca un antes y un después en la vida de las personas. Yo empecé un par de años después a buscar blogs donde había gente joven que quería saber sobre métodos para suicidarse. Y yo escribía en esos blogs y les ofrecía escucharlos. Yo les contaba que mi hijo había muerto, que tal vez la ayuda que le habíamos dado no era la necesaria, que no habíamos sabido qué hacer y que yo les ofrecía mi oreja y mis abrazos virtuales. Entonces la respuesta fue abrumadora. Realmente, y eso hizo que yo empezara a escuchar, después incluso presencialmente, a miles, de verdad, en estos 14 años han sido miles de jóvenes y personas adultas también, que han intentado suicidarse, que han estado con ideación suicida y que en realidad lo que buscaban era alguien que los escuchara, porque la soledad es parte del mundo de hoy. Entonces, ¿qué es lo que aprendí en realidad con esta experiencia en la prevención del suicidio? Es a escuchar, validar y abrazar. Uno se sorprendería de saber cuánta gente no tiene quien lo escuche. Hay gente que está tan sola, que vive rodeado de otras personas, pero que se siente tremendamente sola, aunque tenga miles de seguidores en sus redes sociales. Entonces, lo primero es escuchar con empatía. Lo segundo, validar. A veces nos cuesta tanto ponernos en el lugar del otro. No digo que vamos a sentir el mismo dolor que el otro, porque eso es imposible. Pero sí vamos a validar en el sentido de que nosotros entendemos que el otro sufre. No minimizamos lo que siente, aunque a nosotros nos parezca que tiene todo para ser feliz. Bueno, eso es lo que nosotros pensamos. Esto es muy subjetivo. No sabemos lo que el otro está sufriendo. Entonces, validar, nunca minimizar, nunca juzgar y abrazar. Los abrazos virtuales sirven igual. Si pueden ser presenciales, sabemos que con las precauciones por el COVID es más difícil, pero cuando se puede abrazar, el poder del abrazo es invaluable. Y les quiero contar cómo afecta un suicidio a los cercanos, ¿no? A la familia, a los amigos, a la comunidad en general. Imaginémonos una piedra que cae al agua. Esta piedra causa que el agua suba, ¿verdad? Esa es la bomba atómica de la que yo les hablaba. Y genera múltiples olitas. Las olas son más grandes mientras más cerca de la piedra y más pequeñas en la medida que uno se va alejando. Es decir, un suicidio afecta a muchas personas, sobre todo en los países latinoamericanos, nosotros que somos tan como aclanados, que quizás todavía tenemos un poco de sentido de barrio, en fin, nos afecta muchísimo. Por ejemplo, el suicidio de un universitario afecta a su familia, a su pareja si la tiene, a sus amigos y amigas, a sus compañeros y compañeras de curso, a sus profesores, a las personas que lo conocían porque compraba su almuerzo todos los días ahí o su café. Entonces entendamos que el suicidio, como decía la doctora Otello, es everyone's business. El suicidio nos afecta a todos, por lo tanto todos tenemos que actuar en la prevención, ¿no? Recordemos entonces que más afectados van a estar los más cercanos y en la medida que nos vamos alejando los menos cercanos, pero eso no significa que no estén afectados. Me preguntaba cómo pueden ayudar las personas que ya han luchado contra pensamientos e ideación suicida o que han hecho intentos de suicidio. Yo misma, especialmente después del suicidio de mi hijo, muchas veces pensé en morir, a veces con gran intensidad. La sensación era: yo quiero reunirme con él, yo quiero verlo, yo quiero abrazarlo. Y eso sucede muchísimo. Entonces, ¿qué pueden hacer esas personas? Suponiendo que han avanzado en su proceso, suponiendo que ellos están con ayuda psicológica si la necesitan o psiquiátrica, que tienen apoyo familiar, en fin, que tienen una red de apoyo, esas personas, y todo lo que digo es por el cuidado de esas personas, ¿no? Esas personas pueden dar su testimonio. Los testimonios de la experiencia vivida ayudan increíblemente a otros que están pasando por el problema, porque es fundamental que la gente sepa, y los alivia mucho, que sepan que se puede salir de ahí, que se puede salir de ese agujero negro, que puede ser la depresión u otros trastornos mentales, con un correcto tratamiento y ayuda del entorno, que se puede salir del dolor, porque el suicidio tiene que ver con el dolor psíquico, el psychic en inglés, que es un dolor 24/7, que nos afecta las 24 horas del día, los 7 días de la semana. No hay descanso. Me viene a la mente el ejemplo de las personas, hoy que mañana se conmemora 20 años de la caída de las Torres Gemelas, me viene a la mente cuántas personas saltaron de las torres sabiendo que iban a morir. Y era precisamente porque tuvieron que elegir entre el fuego, morir quemados, y el saltar, que era una muerte menos dolorosa. Entonces, eso es lo que siente una persona que está pensando en suicidarse. Estoy atrapado por mi dolor, por lo tanto la única salida que veo es morir. Y nuestra tarea es ayudarles a que vean cómo hacer cambios en su vida para que vuelvan a vivirla, para que vuelvan a pensar en vivirla. ¿Y cómo podemos ayudar a las personas cercanas a alguien que está considerando suicidarse? Bueno, lo primero, buscar recursos, ¿no es cierto? Aquí mismo en Pajo hay recursos para ayudar a las personas, hay organizaciones de la sociedad civil, como en cada país hay. En Estados Unidos me viene a la mente American Foundation for Suicide Prevention, que hace un trabajo extraordinario. También hay muchas otras organizaciones. Lo primero es buscar recursos para saber cómo ayudar. Y lo segundo, acercarnos. ¿Se acuerdan lo que les dije? Escuchar, validar, abrazar. Iniciamos la conversación. Te he notado triste, te he notado solo, te he notado distinto. Cuando la persona nos dice que lo está pasando mal, le vamos a preguntar, ¿estás pensando en suicidarte? Yo sé que es difícil, pero lo que mata es el silencio. Hablar salva vidas. Entonces le conversamos, lo escuchamos y le ofrecemos ayuda para acompañarlo a buscar al profesional de salud mental que necesita para salir del estado en que se encuentra. Y en realidad podría hablar 2 horas y quizás más de las lecciones que me ha dejado mi experiencia en la prevención del suicidio. Quizás una de las lecciones más importantes es que debemos formar comunidad, debemos formar redes de apoyo. Esta foto de la lámina no es al azar. Se ve cómo estamos unos con otros sosteniéndonos. Esto es, hay un ejemplo muy gráfico que siempre recuerdo. Yo tengo bastantes años de vida ya, y cuando yo era joven en Chile, el circo era una cosa muy sencilla, ¿no? Pero se ponían unas redes para que si el trapecista, por ejemplo, caía, la red lo recogiera. Y voy y comparo, por ejemplo, con el desgraciadamente desaparecido ya Cirque du Soleil, y en el Cirque du Soleil, que es moderno, era moderno, no había redes. Y algunas personas sufrieron graves heridas, algunos artistas o murieron. Ese es el mundo de hoy, sin redes. Más que nunca tenemos información, más que nunca tenemos la compañía de redes sociales, pero las redes que importan, esas redes comunitarias, las que están preocupadas por nosotros, las que no necesitan darnos likes porque sabemos que contamos con ellos, están muy debilitadas. Entonces yo creo que la mayor lección es que debemos volver a recuperar y incentivar desde la sociedad civil y desde las autoridades y gobiernos de todos los países, incentivar la formación de redes, incentivar el sentido de pertenencia. Es tan duro escuchar o leer a chiquillos que dicen, no tengo con quién hablar. Entonces, la pertenencia, que hoy ha quedado tan de lado, la pertenencia a grupos como los Boy Scouts, por ejemplo, la pertenencia a una iglesia, la pertenencia a un grupo deportivo. Sabemos que hay experiencias de abuso que desgraciadamente han disminuido la pertenencia a estas organizaciones, pero yo creo que podemos recuperarlas, convirtiéndolas en lugares seguros, ¿no? Para que las personas tengan compañía, tengan abrazos, tengan apoyo, puedan tejer sus redes. Y por eso todos podemos y debemos ayudar a prevenir un suicidio, como decía la doctora Otello, ¿no es cierto? Y desde la comunidad, de estas organizaciones de base, ¿no es cierto? Grassroots, nosotros podemos ayudar a prevenir un suicidio desde el niño más chiquitito hasta el adulto mayor. Así que ese es mi lema para hoy. Todos podemos ayudar a prevenir un suicidio. Y muchas gracias a todos por la invitación y por haberme escuchado hoy. Un abrazo.
Un abrazo virtual, a virtual one. Thank you very much, Ms. Del Rio. Yes, we can. Yes, we can. And I'm sure you could have speak for more than 2 hours. Very interesting work. We are delighted to have you. Thanks for accepting our invitation and for sharing with us your 14 years of work and how you turn your pain into action to create hope, and which is the theme for this year. And you have definitely provided that guidance to us. Thank you, we appreciate it. I know that for over more than 500 participants, you will agree with me that so far we have had such an interesting perspective in how each one of us, how we could learn about suicide prevention, what can we do for suicide prevention. And so our last presenter today is Mr. Jairo Valverde, Dr. Jairo Valverde, from, he's the United Nations Development Program representative for Guyana and Suriname. So he's the UNDP representative, and we are so pleased that you also agreed to be with us, because together we have a project that covers 3 countries, Suriname, Trinidad, and Guyana, and this emphasize the importance of the collaborative approach. So the mic is yours, Dr. Valverde.
Thank you, Dr. Cayetano. And I would like to start by first acknowledging the powerful presentations we heard before mine. Secondly, I would like to thank the International Association for Suicide Prevention and the Pan American Health Organization for organizing this webinar to commemorate World Suicide Prevention Day in 2021. As the UN's lead development agency, our focus is on strengthening systems and governance to address the development dimensions of health. We support joined-up action within and beyond the health sector. We leverage the power of societies for equitable, resilient, and sustainable solutions. This year's theme for World Suicide Prevention Day, creating hope through action, is very timely. And it's timely because historically mental health has taken a costly backseat to other health and development issues. It has gone neglected and invisible in many places. And it has done so despite impacting every aspect of our lives. Dr. Otello made the point very clearly about how it takes a community. We also heard the very powerful testimony of Ms. Del Rio about how we need to have safety nets, rekindle community, because this is everyone's business. The 2030 Agenda for Sustainable Development marked a turning point for the global mental health response. The agenda is unequivocal on this issue. Mental health is not just a leading health a mental health issue, but also a sustainable development challenge. Mental health is central to the right to health and to the personal well-being, interpersonal relationships, and the well-functioning of full societies. It is also vital to economies. Simply put, it must be prioritized. And just just to go back to what I said, about it being vital to economies, this is not to say that we're dealing only with statistics, but we're dealing with human beings and human lives, as the preceding speakers noted. In shining a spotlight on inequalities, the COVID-19 pandemic has further lifted mental health out of the shadows. There has been no shortage of warnings. The pandemic has sowed the seeds for a major mental health crisis. Like all crises, those already vulnerable will bear the brunt. This includes healthcare workers, older adults, and people with pre-existing health conditions, children and adolescents, women, and people in humanitarian and conflict settings. Therefore, we must redouble our efforts to leave no one behind. Ensuring effective and coordinated national responses relies upon many factors. One critical factor, of course, is financing. And to optimize national responses, we must optimize investments and strengthen economic efficiencies. This requires that we work to strengthen decision makers' access to data on the full costs of mental health inaction, or the cost associated with the status quo response, as compared to the full benefits of implementing proven interventions for transformational change. Undp, WHO, and PAHO have received requests from governments across the world, mainly in this region, for support in generating tailored, country-specific economic evidence to guide their decisions on mental health spending and to support implementation. As a result, UNDP is working closely with WHO and PAHO to deliver mental health investment cases for countries through the UNDP-WHO Global Joint Program to catalyze multi-sectoral action on non-communicable diseases. These cases follow the WHO and UNDP guidance launched this year for policymakers and economists to develop national mental health investment cases. Mental health cases quantify the costs of mental health conditions to a country's health system and economy, and model the return on investment for prioritized interventions. Through a UNDP-led institutional and context analysis, the cases also analyze the barriers to action, for example, stigma and lack of awareness, as well as windows of opportunity, for example, in legislative and planning processes, political leadership, and civil society engagement. The first completed mental health investment case was launched in 2020 for Jamaica. The case focused on anxiety, depression, and psychosis. The results in Jamaica revealed enormous social cost and economic benefits of investing early in mental health. Or put another way, the tremendous cost of not doing so. From 2019 to 2033, scaling up the selected package of interventions would support Jamaica to restore 75,833 healthy life years to its population, while realizing 60 billion Jamaican dollars in economic productivity gains and social benefits. These benefits far outweigh the costs of the interventions, which amount to roughly 14 billion Jamaican dollars, delivering a high investment return. The institutional and context analysis for Jamaica uncovered social and political opportunities to take the results forward. For example, by accelerating a community-based response and transitioning away from hospital reliance. 2, addressing common barriers to the improvement of mental health services, such as social stigma, misperceptions on the cost of and benefits of action, and health workforce shortages. Also encouraging a multi-sectoral response that focuses on this life course while leveraging settings-based approaches such as in-school health clinics, workplaces, and within the criminal justice systems. UNDP and WHO and PAHO are now advancing similar mental health investment cases for 7 additional countries worldwide, of which 3 are in the Latin American and the Caribbean region: Suriname, Peru, and Guyana. These interventions are possible thanks to the generous support of the European Union. With regards to Guyana and Suriname, the cases will break new ground in several ways. First, the scope is expanded to cover additional conditions and interventions, including suicide. Specifically, in addition to anxiety, depression, and psychosis, they intend to examine bipolar disorder, epilepsy, and alcohol dependence. In addition to treatment options, they will model population-based preventive interventions, including pesticide bans to reduce suicide and school-based socio-emotional learning interventions. This is also very much along the lines of what Dr. Otello was talking about earlier with regards to Trinidad. Second, because Guyana and Suriname are both also receiving non-communicable diseases investment case support, the mental health cases will seek to advance efficiencies across risk factors and conditions. For example, efforts will be made to, 1, account for the multiple benefits of alcohol reduction measures for both suicides and non-communicable diseases. 2, join up prevention and treatment efforts to highlight how savings through prevention can be reinvested into treatment and care, in line with the right to health. And third, identify and advance innovative sources of domestic financing for mental health, such as taxes on tobacco, alcohol, and other health-harming products. Third, because the cases for Guyana and Suriname are situated amongst a broader joint support from PAHO and UNDP, they will be instrumental in advancing a comprehensive approach in countries and the region. For example, the investment cases include the ICAs, can inform and strengthen mental health and suicide prevention planning, coordination of mental health and psychosocial support, and capacity for suicide surveillance. A clear opportunity lies in tracking forward UNDP's 2021 Regional Human Development Report. Track high inequality and low growth in Latin America and the Caribbean, which recommends the expansion of mental health care for victims of violence. Indeed, lessons from investment cases supported by UNDP and WHO PAHO worldwide make it clear that the cases are not just economic cases, nor do they simply dump data in the hands of government and decision makers. They actively build coalitions. They inform dedicated programs of support for how to put the case into practice. And they build sustainability into the methodology, for example, by creating space for UN country teams, civil society, and others to uniquely support in-country action. A commitment to evidence-based action informed by investment approaches can also strengthen the appeal of countries to receive development financing external support. A bold and developed opportunity for this region and the world is the recently established United Nations Multi-Partner Trust Fund to catalyze country actions for non-communicable diseases and mental health. This significant new multi-partner initiative convened by the UN Task Force on NCDs will provide support to low and middle income countries to prevent and optimally manage mental health conditions and non-communicable diseases. UNDP is a founding and UN agency of the fund, along with WHO and UNICEF. In closing, let me reiterate that with hope comes action, and with action comes even more hope. With our collective efforts to advance mental health responses, we can prevent unnecessary loss of life and economic losses. These gains can be reinvested in efforts to build forward better from COVID-19, restore progress on the Sustainable Development Goals, and strengthen resilience to the other crises and shocks. But more importantly, it helps us to remember that We're talking about human beings, not just statistics. UNDP looks forward to working with PAHO and all partners to solidify hope through action. Thank you.
Thank you very much, Dr. Valverde. I think your presentation brings a perspective to us in the importance of the returns for investment. But I like the fact that you're saying that the return of, the investment in mental health are not just economic cases. Because when we think of return of investment, we're thinking, economic. But yes, economic is important, but it's also an opportunity to build coalition, to bring agencies like UNDP, WHO together to be able to, have the government see the importance of doing this strategically. And I like what you say, to avoid the guesswork. We don't have to guess. This is the data, this is the information, this is why, and we have tools that are effective that we know we can use so that we, to be able to, do the work for mental health. So thank you so much in bringing that to this discussion. It's 17:03. And so we have, for some of us who is the Eastern countries, depending on the time frame where you are. So we have another few minutes to entertain questions. I really want to thank all our presenters, each one of them. Ms. Del Rio did a fantastic presentation, Mr. Valverde, Dr. Otello, Dr. Oliveira, all of you brought something so relevant to this discussion. So we have a few minutes for presentation, and I will encourage you to open your video so that we can entertain the questions. I have some that I will read to you, and then you can let me know, because we have so many questions. Listen, we have been joined by over 514 persons today. And I know this morning when I were looking at the registration, we had over 1,400 people that registered. So this is a very interesting topic, and people are eager to learn and understand what to do, how to support a family member, loved one, and what is there that we can do. Okay, so I can, if I'm missing some and you happen to see some of the questions, please let us bring it to our attention. But one of the things that they are saying to Dr. Otello is a very impressive effort by the Ministry of Health in Trinidad. What do you have in mind for the implementation of the strategy? How will you oversee this? Which sectors will be involved? Then there was another question to you too. In your experience, what has been the reasons and facilitators for suicide for Trinidad and Tobago to reduce their suicide trend? So I think I will leave it there, and then have you answer, and then we'll have other questions for other panelists. Thank you.
With respect to the implementation, we're just in the process of developing our implementation plan, which looks at the strategies, the evidence-based strategies, many of which were mentioned today, both in my presentation and by the other speakers, and looks at the multi-sectoral approach to implementation. In other words, we're not going to just own this as the Ministry of Health. We recognize that health alone cannot do it effectively. So we're going to be collaborating with all the different government ministries, social service agencies, non-governmental organizations, and other private sector entities that have an interest in mental health, so that we can have the widest range of participation possible, so that implementation takes place at every level of society. Implementation can't happen in our offices. It has to happen in the homes, in the schools, in the workplaces, where people congregate, where people hang out. So that's why we're approaching it from that point of view.
Thank you, we appreciate that. So I have a question here and perhaps this could be for Dr. Olivera, which just said, what would you recommend if we as MHPSS workers refer a person with suicide risks, but it does not receive proper intervention? Because as we all know, there is a lot of public health requests because of COVID. And so there's a high volume of people needing mental health services. So people receive more, COVID has sometimes negatively, maybe, I guess this is what they're looking at, but what would you recommend when it comes to people who need care, and then because of these services, health services focus more on COVID, they may miss the need for mental health care?
Thanks, Claudina, and thanks for the question. I myself, I face those situations in the different places that I have worked in the past. You are in an emergency and you receive someone with very high levels of distress, or someone who might have a severe mental health condition that in fact you don't have with you the capacity to properly provide the necessary support. So the first thing that usually comes to your mind is, I need to organize a referral, but in fact, in many places, in many corners of the world, a place where you can refer and the person can receive that level of care, unfortunately, do not exist. So, I mean, very practically speaking, that's in fact a motivation for us to develop capacities at the community level. So if there is no place to refer, I have no choice than developing training, capacity building, increasing the capacity of staff and community who is in that specific locality to be able to address those problems. Of course, this cannot become a reality from one day to the other. Capacity building takes a bit of time, but it goes in line with what we have been asked, which is scaling up mental health care from a multi-sectoral approach. So everyone has a role to play. A community member can support up to a certain level. Professionals at primary health care can do a lot. And might be able also with the proper training and supervision to address severe mental health conditions. So I think the way forward here is to develop capacity, training, capacity building, and supervision of whoever might be available to provide different levels of mental health care.
Thank you, thank you. There's so many questions, so I will be randomly selecting some of them, but there's one here that I think maybe Ms. Paulina, you probably can help us with. They're asking, there's so many methods, so they're saying, what would you recommend, what do you think would be the signs for people, especially because sometimes there is no specific sign, and this could be, the suicide can be just, no siempre dan señales claras. That's the question here. Yeah, they don't normally give you clear signs. So what would it be recommendable? What are the strategies? So I think because of your personal experience and the work that you've been doing in this area, it may be good for you to give us your perspective. Thank you.
Claro que sí. Yo creo que lo principal que debemos estar atentos es a los cambios en las personas, cambios de conducta, cambios de ánimo, ¿no es cierto? Como por ejemplo el aislamiento, que es una señal muy importante. Los cambios, por ejemplo, en la comida, el sueño. Una persona que antes dormía mucho, ahora no duerme, cosa que es muy mala cuando uno está en riesgo suicida, no dormir, buscar ayuda profesional, por favor. La otra señal, las personas más irritables, ¿no es cierto? No es mi campo, pero sé que eso podría señalar depresión, una persona que la vemos más irritable. Ahora, también debemos fijarnos en personas que, como lo nombraron antes, están acumulando medios letales. Si descubrimos que alguien está escondiendo tabletas de medicamentos, por ejemplo, si descubrimos que alguien está escondiendo un arma de fuego, municiones, si descubrimos que está escondiendo algún elemento tóxico, eso debe alertarnos tremendamente y debemos actuar de inmediato, ¿ya? Lo más importante es estar nosotros atentos a los cambios, porque muchas personas los ocultan. Y sepamos también, no quiero alargarme demasiado, pero es importante que sepamos que la inmensa mayoría de las personas que se suicidan sí lo anunciaron en algún momento. Lo que pasa es que a veces los anuncios son muy velados, como por ejemplo mi hijo que me dijo, ¿para qué planificas las vacaciones del otro año si a lo mejor yo no voy a estar? Nunca se me ocurrió que podía hacer eso, ¿no? O pueden dar señales específicas como me voy a matar, y nosotros debemos actuar pero inmediatamente, y no debemos permitir que en los servicios de salud, que a veces sucede desgraciadamente, se le baje el perfil al riesgo, ¿ya? Debemos actuar de inmediato y no dejar sola a esa persona. No sé si estoy respondiendo bien la pregunta. Excelente, muchas gracias.
Muchas gracias. Thank you. So there is a statement, and I will follow that with a question for Mr. Valverde. So what the person is saying is that they have noticed that some investigation, they didn't say which investigation, but there is a number of mental health professionals in the world, very small. The gap is very small. It's 1 for 25,000 people, you know, and that clearly creates a gap when it comes to professionals to support, provide care. So maybe the question to you would be, what do you think is the role of UNDP in financing mental health and suicide prevention in the region? What are some of the lessons learned from your work? Thank you.
All right, that is actually a very complex question, and I don't think I can, fairly respond to it in full. I'll start by sort of, highlighting that, as a development agency, we support governments in their efforts and provide technical support. So this is sort of, the bureaucratic side of the answer, if you will. The issue of the professionals is why we have so few professionals in some societies. I would say that that's tied partly to some of the issues we discussed today. I mean, in societies where there's a social stigma attached to suicide, or maybe let's not say even that there's a stigma, but there is a culture of not talking about it. It doesn't help create the demand and sort of a natural, organic pressure from society, or maybe more demand for health professionals. Partly because people don't want to say, I am depressed, or it could be it could be something less severe. Also, some societies are sometimes focused on what they consider the urgent issues, right? They might be saying, okay, I'm dealing with, I still have a lot of people who are going hungry. So I need to move my resources to that. And so the universities themselves, sometimes in countries, have this approach. So, to get back to the question, I think it has to do, on the one hand, there's the clinical aspects of dealing with suicide and the attempts at suicide. Then there's the public health policies that Renato alluded to, and Dr. Otello. And then there's the broader issue of dealing with this as a development issue. And to deal with it as a development issue requires the work of everyone to change the culture towards mental health. Because if you don't change the culture, it's very difficult then to go to a government and say, we can support you in developing your structures. Or even for a government itself, might be difficult to sell to some segments of society saying, look, we need to increase our investment in mental health. So it's, I wish I could give you a quick and simple answer, but but this is one difficult area, and as I was mentioning when I spoke, mental health for a long time in many societies was sort of neglected or ignored. And even though we have made great strides, in many places it still remains a difficult subject to acknowledge at the individual level, at the family level, and even for societies. So I'll stop there.
Thank you very much. And you know, it's not, I totally agree with you. It is a complex issue. It's not something that, if it was easy, we would have the answers. You know, we have effective interventions. We have, we know about research. We know about so many people who are committed to make the difference, and yet suicide continues to increase. So I totally agree with you. I think you make a very fair point in terms of the issue of stigma, the issue of discrimination, the issue of, that it has been neglected, but somehow now, and we're very, very pleased to partner with Undp when it comes to providing that funding to be able to work with countries and put mental health on the agenda. And I think it was mentioned by Dr. Otello, the project that we're working with, to look into surveillance or look into data to understand a little bit more. So no, you did allude to some of these issues. Thank you very much. Time is of essence. This is such an interesting and exciting, and I really enjoyed this conversation, but definitely everything that good has to have an end, and we are now past the time where we want to wrap up, and the section of question and answer, and as I said, a link has been posted there for you to go to our website to get the more information, and I definitely want to thank you for all of you, our panelists and people who have joined us today for contributing to this rich discussion. I now want to pass the mic to Dr. Oliveira for the closing remarks. Over to you.
Thanks, Claudina. First, I'd like to thank all our presenters for their contributions and everyone who joined us for today's webinar commemorating World Suicide Prevention Day. All of us can feel the loss of the nearly 100,000 deaths due to suicide in our region each year. These tragedies, as our colleagues have mentioned, really impact not only individuals directly who are touched by them, but the family and the wider community. Even one life lost to suicide, it's one too many. So yet, despite our efforts to date, we have not succeeded in reducing the suicide rate in the Americas. In fact, this rate has only grown in recent years. And the incredibly difficult circumstances brought on by the COVID pandemic threatened the mental health and well-being of people across our region. But as we have seen here today, there is hope. Many suicides can be prevented. And the panelists here today have shared the different ways that we can prevent suicide. As we have heard, we all have a role to play in preventing suicide. Through multi-sectoral collaboration and effective evidence-based interventions, countries can proactively advance suicide prevention. And we can support people struggling with suicidal thoughts and those with lived experiences of suicide by dispelling the stigma associated with it and encouraging them to share their stories. So we believe that together we can all take action to turn the hope of preventing suicide in our region into a reality. So thank you again. Thank you for all of you for joining us. And I wish you a nice day. Thank you.
Have a good weekend, everyone. Thank you.
Thank you, everyone. Have a nice weekend.